Hi, everybody. Thank you so much. I'm really happy to be here and really hope that you can get a better understanding of what dementia and dysphagia are. So let me just go ahead. Next slide, please. I just want to say thank you so much for all of our sponsors supporting this effort to help provide encouragement and empowerment to caregivers. I'd like you. Next slide. That we have no relevant financial relationships to disclose. Okay, so what are we going to accomplish today? Well, today, between the two of us, we will talk about identify the common symptoms and causes of dysphagia in older adults, explain the indications and functional outcomes of these swallow evaluations, learn some techniques to optimize mealtime for different stages of dementia and dysphagia, and to how to prepare consistencies of food, to optimize enjoyment, and to discuss issues regarding tube feeding for adults with dementia. It's a lot of stuff to cover. Next slide. So first off, what is dysphagia? It's a medical term. Don't want to let you scare you, right? It's like actually Greek foundations, right? Greek dys is for abnormal, bad or abnormal, and phagia is eating and swallowing. So basically, dysphagia means abnormal eating and swallowing. So there's some difficulty in swallowing food and liquid. Next slide. So how common is dysphagia? It's actually pretty common among residents living in nursing homes or assisted living facilities. About 40 to 60% have some kind or some level of difficulty swallowing and eating. A lot of it is related to dementia, 13 to 57%. Many times it's also related to stroke, and many times it's related to Parkinson's disease. Next slide. What are some signs? I'll give you a clue that there might be some trouble, difficulty with swallowing. Well, there might be some coughing, choking, or gagging. You might notice a hoarse voice or a wet voice, drooling, trouble, regurgitation, reflux, heartburn. Might feel like something lump in the throat, takes a little more effort to swallow, might automatically try to eat selectively, not so dry stuff, maybe more moist, more purees, pain with swallowing, or actually there's some people who have no symptoms at all. And then that's kind of when it's dangerous because you don't really even know that you're having a trouble and food might be going down the wrong pipe. So yes, next slide. So what happens if you have trouble eating and swallowing? Well, you can't get as much food down as easily. So some weight loss, sometimes malnutrition, and if you can't drink easily, dehydration. And if things are going down the wrong pipe, then choking or what's called aspiration. And if the aspiration gets into your lungs and gets infected, you can get pneumonia. And because this might be a recurring problem, recurring pneumonia, recurring fevers, compromised quality of life. And usually if you start seeing trouble with swallowing and pneumonias and difficulty with eating, it's usually a symptom of some other underlying medical condition. As I mentioned before, sometimes maybe dementia, stroke, or Parkinson's that may be in its early stages starting to manifest itself and needs to be looked into. Next slide. So let's review a little bit about what is the normal swallowing phases. There's actually 3 phases to swallowing, right? 3 parts to the swallowing process, right? One, first, it goes through your mouth. The food and the liquid enters your mouth. You chew it, you mix it with saliva, and you push it to the back of the throat. That's part 1. The second is called the pharyngeal phase, which is the back of the throat, where it enters and passes through the pharynx, which is where your windpipe is, and it has to get through that successfully in order to swallow into your stomach. And then the third phase is the food going through the esophagus, down that pipe, the food pipe, into your stomach. Next slide. And I forwarded that pretty fast. Okay, next slide. Okay, that's the food going down the back into the stomach. Next slide. Okay, so what kinds of problems can happen when what kind of difficulties you might have in your mouth and the back of the throat? Well, maybe holding food or liquid in your mouth, like sort of what we call pocketing, right? So not swallowing it, just holding it in your mouth, or prolonged chewing, or food that's spilling from the lips or the nasal cavity, having trouble with the drooling and coming out, drooling, dysarthria, trouble speaking. So you can't manipulate the tongue as well. And so the words come out all slurred. And so the same thing, the tongue needs to manipulate the food, and it may have trouble pushing the food into the right places as well. So coughing during or shortly after eating and drinking is another um, sign. Maybe you may feel like food is sticking in the back of the throat, or you might have a wet voice during or after swallowing. Next slide. And what are some causes of that? Well, if you have a stroke, some neurological problem like dementia or Parkinson's disease or other neurological conditions, it may impact your ability to manipulate the food in the mouth with the chewing and the moving the tongue correctly and pushing things to the back of the throat and opening. So that's the stroke, dementia, and Parkinson's are very common causes of this oral pharyngeal um, trouble swallowing. Sometimes medications can contribute to this as well. If you have medications that cause dry mouth or sleepiness or poor appetite, that also impacts your ability to chew and swallow. Cancers in the head and the neck, of course, if you have masses and you know lumps or stuff or pain, ulcers or things like that, pressing on your tissues in your mouth, that will also may cause pain and difficulty with swallowing. And of course, weakness. If your tongue and your swallow muscles are weak, that will also. So even if you got very, very sick from, say urinary tract infection, and you were hospitalized and you were deconditioned and you were there for, a couple of weeks, that overall weakness will also, may also contribute to weakness in your overall health and your chewing and your swallowing abilities. Next slide. So where do we go with that? So, well, first is to assess the problem. So we usually do that through a clinical swallow evaluation. So somebody like a speech and language pathologist would review the history and the problem and where the source is and examine your mouth and then assess your swallowing. So basically she's going to test different textures of food and test different consistencies of liquid and sort of see which are the ones that you might have trouble with. Next slide. Okay, that's the referral to the speech and language pathologist. That's a speech therapist. Next slide. Okay, so what's the purpose of that? Well, first is to sort of identify the problem, but also the speech and language pathologist will help you find solutions, so trials of compensatory or rehab techniques. And so say, okay, so if you're having trouble with dry foods, let's just add a little moisture and see what happens, right? So they help determine the optimum food and liquid textures by mouth that you would need to eat safely, strategies for safe and efficient swallowing. Uh, there are lots of different techniques out there. Might be things like alternating food and liquid or double swallowing or things like there's lots of techniques. Counseling, education, and training to really facilitate that swallowing. Um, there's a personalized treatment plan. You may need a referral to a dietitian or a gastroenterologist if the problem is a little more complicated. And actually, if they think it's completely unsafe to eat anything by mouth, then they're going to recommend nothing by mouth at all. But of course, that will come with a different conversation as well, which we'll talk about later. But a swallow evaluation basically determines how they how you may be swallowing and where the trouble might be, it doesn't actually determine whether or not food is going down the wrong pipe. In order to do that, you need to actually get a video swallowing evaluation. It's a separate kind of evaluation. Next slide. So I'm just going to move on to the next phase. Remember that third phase of swallowing where the food gets past the mouth and the back of the throat, and the food is going down the esophagus, down the narrow tube into the stomach, right? And so sometimes there's problems with that. If there's a mass in there, like a cancer, or there's some kind of stricture, right? Then there might be pain with swallowing, might be unable to swallow, might feel that food is stuck in your chest or behind your throat. You might feel hoarse. You have this heartburn or regurg, food is backing up feeling. You might feel like you have to actually cut food into smaller pieces, and you might need to have chopped or minced or food instead, or purees instead of just chunks. And esophageal dysphagia may have some respiratory problems like asthma or infection because of the reflux of the food coming up the pipe and up the stomach into the pipe, windpipe. Next slide. So some of the causes, right, well, could be, as I mentioned, mechanical, right? If you have cancer, you have radiation treatment, and there's a structural problem, then it blocks the swallowing or causes it to be more painful. There are also things like motility disorders. So sometimes the structure might be okay, but the esophagus, which is actually full of muscles, goes into spasms or something like that. And so, or it doesn't squeeze at the right time, the timing is off, then you can have things like achalasia or esophageal spasms or things like that. And then also there's weakness as well. So if your just general condition is very, very weak, deconditioned, you can also have trouble with the esophagus muscles as well. So everything is weak. So these are some causes for the esophageal dysphagia. Next slide. And if you have trouble with this part, then oftentimes you are referred to the GI doctor, the gastroenterologist, the doctor specializing in the stomach. Okay, and usually what might happen, the doctor might do this video swallow evaluation like I talked about. So if they think that maybe food is going down the wrong pipe, or you have problems with your esophagus, right, or they're not really sure if it's that safe to eat, then they will determine whether or not a video swallow evaluation is indicated. Next slide. So this is a fancy thing, a video fluoroscopy swallow study is a modified barium swallow. So this is what happens is it's like watching a live X-ray. You're having you sit in the X-ray room, and they have a video, X-ray video, looking at your back of your throat and your chest, and giving you food that has a little bit of a barium in it, and then seeing how that food moves down, and so that gives direct visualization of what is actually happening to the food and whether or not it actually clears as it goes down in its path towards the stomach. And then it can also help determine, how diet changes and compensatory strategies we talked about can help with swallowing and making it better. Next slide. There's also other ways you can actually, the gastroenterologist doctor can stick a tube and look inside the back of your throat as well. And look, see, this is a view of the pharynx, which is the voice box. And they can sort of see, oh, look at that. Let's see what happens when they swallow. And they can see if it closes well or if it doesn't, or if it's asymmetrical or something like that. And they can observe the flow of the food and the clearance of the materials through a camera. So that's just another fancy technique that sometimes some doctors may use to assess the swallowing. But these are all there's a quite invasive. It requires some sedation and can't be able to follow directions, and it's so uncomfortable. Next slide. Okay, so what's the purpose of this? Is to diagnose if there are abnormalities in swallowing in the pharyngeal phase, to see if there's aspiration going on that is silent, that we're not actually. So there might be food going down into the windpipe that we may visualize on these x-rays and videos, that the patient is not even coughing. They can't tell, and it's just going down the wrong pipe, and that will tell us too. It will help us figure out how to compensate and facilitate better swallowing. Sometimes there's biofeedback, there's exercises, there's training. Maybe there's a referral to a dietitian, or anyway, there's a personalized treatment plan based on a very comprehensive swallow evaluation. Next slide. Okay, so what are the management and treatment options? Well, I guess it kind of depends. There's many ways of trying to address these issues. Counseling, education, and training is really the main interventions here. So a lot of times there's exercises, and so oftentimes the speech and language pathologist will give you exercises for your mouth and your throat and your voice to strengthen them, and also strengthening your breathing muscles as well. And there may have fancy things like nerve and electrical stimulation, but usually it's just those exercise and muscle strengthening things that they can help work with. There are dietary considerations. So maybe right now it's not safe to have the big food. We have to chop it up. Appropriate textures, preferred food and drinks, get the proper temperature, smaller, maybe more frequent meals, more accessible snacks, very high quality, very efficient and packed with proteins and nutrients, things like that. Feeding and behavior strategies, making sure that the person is alert at the time of eating, not sleepy. Positioning of the body, sitting up straight, leaning, tuck the chin in, those kinds of things. Maybe changing the rate of feeding, not so fast, take it a little slower. Maybe where do we put the food? How do we put the food? And then different swallow techniques, like swallowing a couple times before introducing the next bite. So there's a lot of different strategies that can be taught as well. And then, of course, there's environmental modifications to be less distracting, improve the posture, support self-feeding and prompting and reminders, and just optimizing communication and making mealtime pleasant. So it's just not this negative event and stressful event. So this is lots of different strategies for trying to compensate for difficulty with eating and swallowing. Next slide. Okay, now this sometimes, especially after somebody's had a big stroke, I'm sure some of you have seen this, right? It's just, gosh, they can't talk, they can't swallow, they're not alert. It's very, very difficult, and maybe it's just not safe at all to eat or drink at this time, and that's what we call NPO, nothing by mouth. And so sometimes doctors at the hospital may recommend, maybe we can't put anything in the mouth, and we might want to suggest a feeding tube. And so I just want to throw in, I think it's really important to be well informed about feeding tubes. Feeding tubes is not a quick fix or a quick answer, and it doesn't really solve a lot of problems. And there's a lot of considerations. And so I think it's worth just talking about. There are risks and benefits to feeding tubes. So gastric feeding tubes actually can go in different ways. One, very common way initially is that they actually put it through the nose, and then they tunnel the tube all the way to the back of the throat through the wind the pharynx, and goes right directly into the stomach all the way down. That's very uncomfortable actually. Or if it's more longer term, then they put the tube, poke a hole. It's a surgical procedure right directly into the stomach. What's the benefit? Well, it's easier to feed, less time, it ensures a caloric intake. But the problem is it it only benefits those not in the last stages of illness. So if they had an acute stroke, a head trauma, or they're critically ill with a good chance of recovery, maybe they have head and neck cancer or ALS, young patients or more functional patients. The risks for these feeding tubes is that decreased quality of life. We often see that, oh, then it's easy. You just pour the formula in and just walk away. And there's less human contact. There's no gratification of eating and tasting, sensing food, restraints oftentimes because it's so uncomfortable that people feel like they need to pull it out. And then if you pull it out, of course, that's a whole other surgical procedure to put it back in, and you can go round and round with that, and you cause injury. And so then they restrain them and tie them up, and then that's inhumane. And so that's a whole other, ethical issue. Feeding tubes if you're not feeding at the right rate, you can have nausea, vomiting, diarrhea. The site itself can have bleeding, infection, skin and irritation, leaking. It could get blocked, can fall out, could get pulled out. I've seen this so many times and time again. Every month they're going in, complication after complication. Increased risk for pressure ulcers because they have to be staying in one position for a long time. More likely to get aspiration pneumonia because if you're putting the food directly into the stomach, it could actually back up and go up into the lungs. And more likely to get fluid overload because you cannot actually regulate based on feeling your own body needs. You can, especially if you have other conditions like heart or liver or kidney problems, you may run the risk of getting fluid overloaded and congestion. So you really have to balance these benefits versus the risks. So when does this benefit and risk ratio kind of play in? It's very, very individual. I think it's helpful to realize that tube feeding does not help when you have end-stage disease, when you have end-stage Alzheimer's or end-stage Parkinson's, terminal cancer, stroke that has no chance of recovery, a persistent vegetative state, or a very, very poor prognosis. Because tube feeding, while it provides the calories, it does not prolong life. It does not provide weight gain, does not prevent aspiration, does not help with the pressure ulcers, and pressure sores may in fact make it worse, and will not help them improve their functional status. So you have to be very clear, like, okay, what are the goals here for this feeding tube? What are we looking for in terms of risk and benefit ratio? And is this decreased quality of life and risk for complications worth it? If it's a temporary situation, it might be worth it. If it's long-term, or if the condition is going to progress, it may not be worth that quality of life trade-off. So there's a lot. These are really things to sit down and consider very carefully when thinking about this. Next slide. So yeah, when we're thinking about this process, we have to find out really what is the most important thing to this person at this time in their life, and ask them, does this tube feeding help meet these goals? And consider if that person is in the end stage of their disease process. And I just want to mention that the natural dying process is not necessarily painful or uncomfortable. Oftentimes, as people become more frail or they're naturally dying, they actually have a smaller appetite. you're not really wanting to take in that many calories anyway. And only a small amount of food and drink is really all they would like. And usually that would be for quality of life. Um, and you have to consider both the medical facts, as I mentioned before, as well as, subjective, what would they like. Um, and of course, a time limited trial is always an option. You can always say, oh, well, why don't we do a 2-week trial of a tube feed or something like that? And if it's not going well, then let's just stop it. It's always okay to stop. The decision to start or withhold them is really usually not emergent. It's something you can sit down and consider very, very carefully, because quality of life is at stake. And the thing I would really like people to think about is that eating is about I mean, feeding and eating is synonymous with love and life, right? And so, in quality of life. So maybe just focus feeding on quality of life rather than just for calories, and whatever they take in, that's good enough. And have small amounts for pleasure and taste, and don't worry too much about the amount, um, in order to maximize that quality of life. So those are just some of the considerations. Next slide. Okay, so what are some suggestions? So, if the appetite is poor, as a geriatrician, as a doctor, I would also look at constipation. Make sure when people are constipated, their appetite goes down, right? If they are sick, they're having an infection, appetite will go down. If they're feeling depressed or have some other anxiety going on, appetite may go down too. So really, we need to think about the holistic approach. If there are medicines that are making things worse, making the eating problems worse, stop those medications. If sometimes dental issues can also impact eating and swallowing, and so make sure dental issues are addressed. And then careful hand feeding. Favorite foods for quality of life. If they like chocolate, that chocolate it is, right? Um, and then just very small amounts, very careful, small, and take your time. You have all the time in the world. It can take 3 hours to feed one meal. I mean, I've seen that happen, and that's just more rich time that you have with your loved one. So that's much more highly preferable than tube feeding or force feeding. Um, hospice referral as well, because oftentimes if the intakes are eating is getting harder and harder, then likely the functional condition and the medical conditions are declining, or the disease might be progressing. And so the hospice will help support that natural dying process. And then there are other ways to show love, not just food. You can provide massage, you can read, you can play music, and other things, other ways to show love. And next slide. And then finally, I just wanted to mention this is the dysphagia video that was produced a few years ago that you might find helpful. It's actually translated English, Portuguese, Ilocano, Samoan versions, and we are planning on Chinese translations in the future as well. So just wanted to give you a heads up on that. And I'm going to pass this on to Dorothy to give us some more practical aspects. Thank you, Dorothy.
Hello. Thank you so much, Dr. Wen. That I always learn something new when I watch your presentations. Yeah, I would like to build on what Dr. Wen shared about um, the, the physical aspects of what's happening when someone is experiencing swallowing difficulties, and look at it really specifically in the world of what's happening for people who are living with dementia. And so a lot of times we think about someone who's living with dementia, and it's very much they're having a problem, and then there's us. But I want to have us, if you're sitting in a room, don't be embarrassed, you can use your hands. They're all of us. It's all about all of us, and touch your head. about all of our brains. And eating for all of us is such an important part of our day. One, it happens multiple times a day. We got generally 3 meals, and then Lord knows we snack as well. Um, and it's a full sensory experience. You know, smell, taste, touch, right? All those kinds of things are happening for us. But we're looking at it. Sometimes we even hear it. It's sizzling. It's, you know, all those kind of things. And that's true even if someone is living with dementia and living with dysphagia. There are ways that we can connect the senses to the experience of eating. So why not make it delicious? So it is true that I also have a background, in addition to social services and dementia education, I have a background in culinary as well. At one point in my life, I decided I wanted to go to culinary school, went to KCC, and uh, that's actually how I entered into the world of dementia. I was looking at how people living with dementia need different uh, changes in the way the food is presented and the different kinds of support for food. So as dementia progresses, so again, I had you kind of touch your head a little bit. You know, when we think of dementia, we most often think of which symptom? Memory, memory issues. That's generally what people think about. But the whole brain is affected, and that includes all the things Dr. Webb's mentioned about the involuntary functions of eating, and also the voluntary ones, how we perceive what we're looking at, how we perceive what things taste like. All those are changing because it's a whole brain experience. So as the dementia progresses, we're going to be looking for overall changes in health. Oh, that denture and mouth problems issue. You know, even if someone has dentures, and you lose a little weight, that denture is going to be slipping out, slipping out of your mouth all the time, and that makes eating a challenge. Drug interactions, and when we're seeing those kinds of changes, you know, is this? How do we know? Is this the advancing dementia? What is going on here? So this is where I want us to take a moment to think about human skill. So I'd like you to take your 3 fingers here, your 3 fingers here. So when we think about skill and fine motor skill, we most often think of our little these fine motor fingers. Like, so if you're going to thread a needle, everybody thread a needle, great. Button your buttons, take your glasses off and on, your earrings. These are all a little fine motor skills. So we have fine motor skills, not just in our fingers and toes, I'm wiggling my toes, but in other parts of our body as well. Some things we use more for strength, like you have one leg that has more skill and your other leg is the one that you would balance on. So which foot do you put your pants on with first? That's your skill foot. And the other one is your strength and balance foot. When you do it the other way, not so skilled that way. But it also goes for your oral skills, fine motor oral skills, with all dementia, whether it's Parkinson's, Alzheimer's disease, strokes, 100 more. Skill, do this. Skill is lost first. Gradually, we start to have trouble with those fine motor things. These last 2 fingers go like this, strength. So like a plier, hammer, strength remains. Same with fine motor skills. So I'd like you to imagine eating something delicious. And you're going to pick it up. I have a prop. You put it in your mouth. And just imagine eating it. Notice what your mouth does, your jaw. Your lips are working hard to keep it in to stop it from dribbling. Your tongue is moving that sucker around. Your cheeks are making adjustments, right? And finally, your throat helps you get it down. And without even thinking about it, you don't inhale it. And then there's the skills that involve with the different kinds of foods. So some things you suck up, some things you have to bite, some things you have to crunch, some things you have to lick, some things you have to chew. You know, we don't think about it, but there's a lot of different skills involved with eating different foods. And as your brain is changing with dementia, because there's actual physical uh, wasting, shrinking of the brain, as well as the wirings dying as well, we start to have trouble with these things gradually. And so those signs that Dr. Wen mentioned that we were watching for are all about in the world of dementia, the later stages of dementia in particular, losing these skills. And so I'm going to have us all put on detective hats and think about taken a step back and watch and becoming really good detectives to watch and notice. So I notice that someone's getting it in, but not really chewing, and it's just sitting there. That's a clue. I notice the pocketing. I notice that they suck things pretty well, but things that you have to chew a lot, like meat, they're spitting back out and putting on the table. Maybe they suck all the juice out of the meat and take it back out of their mouth and put it on the table. Those are all clues to a changing brain. And so I want to take a look at um, the progression of brain change. So this GEMS circle here, starting at 12 o'clock with sapphire, going around to diamond, emerald, amber, ruby, and pearl. This is in the positive approach to care trainings, what we use for looking at the changing brain over time. It's actually based on the Allen cognitive levels, which is an OT, occupational therapy level, that includes sapphire is a normal, typical brain, aging brain. So guess who that is? That's us, by the way. We have brains in the circle too. And then in going from diamond, emerald would be the earlier stages of someone living with dementia, amber later, emerald, amber later, and then ruby and pearl would be the end. So you can see I've highlighted the ruby and pearl because this is where dysphagia really comes to the forefront when we start to see the real loss of skill. And you can see under rubies, by the way, the colors correspond to a lot of traits and things happening with the progression of dementia. But if you look at the green, yellow, red, looks familiar? Stoplight sequence. Go, slow, caution, and then red. That is the red of the ruby is where fine control in all parts of the body starts to really fall away, and that includes eating. And then the last one, the pearl, is the very end stage of someone reaching towards the end of their life, where they're more like a oyster clamped shut, more contracted, really, really hidden the shell. Very few moments where eyes are open and that we can connect before it closes back up. So we're going to be looking at these two gems in particular around the changes. So remember those skill fingers we held up? So if you have a pen with you, I have a spoon, but you can hold a pen. Imagine it's a spoon and notice what fingers you're using. So if you're going to eat, what are you going to do? It's those skill fingers, right? If you need to scoop something around like this, you have a lot of skill. You don't have these skills in your hands anymore. So what will you see someone who's living in a ruby state? Which fingers are still working really well? The strength ones. You might notice holding like this instead, or not able to use a utensil at all, maybe using more whole hand picking food up this way. So if I'm able working with looking at what person still has and be able to use how can we modify the food and the presentation so that they can successfully get it to their mouth. So if this is an unholy mess and making you crazy, you use a spoon, is there a way that it could be changed to more finger foods or smaller size foods or whatever they need in that moment? And like Dr. Wen said, it's very individual. These are things that we, again, with being a detective, look at what we need to do. Whole body positioning. Um, Now, the hypersensitivity. So if you touch your nose and mouth, if you imagine you have an oxygen mask on here, this is a very hypersensitive part of our body because there's a lot of nerve endings here. There's a lot of data we have to take in through these organs. Also, fingertips, toes, and genitals. Also, we take in a lot of data there too. And as the dementia is progressing, it's almost as if someone took the volume knob, for people who remember knobs that turn by volume, and crank it up. It was already hypersensitive, sensitive compared to other parts of our body, but now in these later stages, it's hypersensitive. So this is too, something that doesn't seem hot to you seems extra hot to me or extra cold to me. That I become hypersensitive. I also start to really have trouble with sequencing. So I have trouble getting started, or once I start, I cannot stop. So you give me some food and put it all out, and you even put this spoon in my hand, and I just can't get started. just what somebody helps me get started, I can keep going. But then once I keep going, this bowl might be empty and I just keep scraping, 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 and I can't stop. And that is, again, another clue to the change in brain that this is a later stage of living with dementia, a later stage of brain change, and I lost the ability to end that sequence process. Because we all know how to start eating something, go through all the steps of eating it, and then we're done. We put that spoon down, we're done. We're not going to do any more, unless of course it's delicious and you want to lick the plate. But that is a different skill. Um, Changes in vision, what we can see or not see, this monocular vision. So if you were to think about, again, with the changing and dying brain, I can only take in so much data. So if you take your hands and going through the stages of dementia, you're getting smaller and smaller, and your area of focus gets smaller and smaller with a binocular till finally in the ruby stage, you're here at the monocular level. So if you put one monocle on and cover your other eye and look down at your table, imagine there's a plate there, and notice what you can see, and then kind of uncover the other eye and look and cover it. You kind of see that you're missing your depth perception and you're not seeing part of it. I remember we had a resident at Halikuike who would eat exactly half of the plate. So what was on the plate, half was eaten, the other half wasn't eaten. And if you flip the plate around, she would eat the other half. And it took her a while to figure out that she wasn't blind in this eye, but she was not processing the data from that eye anymore. Everything needed to be on the left for her in this particular case. Again, that's a detective skills. It took a while. Yeah, detectives don't figure things out quickly. And then thinking about the pocketing and holding. Again, that's that sequencing we talked about when I was talking about I can't stop scraping the spoon or I can't get started. I get the food in, but all the steps that you did when you were imagining eating something delicious, I got it into my cheeks, but how do I get it to the next? I just stop at that step. I can't proceed any further. So the main message is at this stage is because I've lost so much fine motor skill, but I can copy. So be eating along with someone, slowing down, simplifying your instructions to one or two words, and possibly assisting with hand under hand. And I have this little wooden hand here that when I say hand under hand, so you, the computer, are my friend that I'm assisting eating. I'm holding your hand underneath and it's helping this way. So your hand is involved with feeding yourself. So I'm not feeding you, I'm helping you eat. This is something that can be very helpful when, again, that skill is missing. This hand skill is missing, but together we are one functional hand and brain together. And decreasing the duration. So, if it's a struggle, and it's taking hours to eat, and it's frustrating for both sides, you know, taking less time thinking about calorie density. So that means high amount of calories in low volume foods. So things like ensure high calorie density that can make a difference. Um, so there's some possible things. Some of these are things Aida already mentioned, about weight loss, refusal, all these kinds of things, pocketing. Who said you have to stay seated to eat? If this person is on the go, it's okay to walk and snack. Yeah. This one here is super sweeting. One of the things that changes as time goes by. I don't know if we were in a room, I'd ask you to raise your hand if you've noticed this, but uh, they start things that they enjoyed sweet before. Let's say with one spoonful of sugar in their coffee, you start noticing they're putting 5, 6, 8 spoonfuls of sugar. It's like, oh my God, what are you doing? This is the super sweeting. Said, I need that much to trigger my brain that I'm getting this. And your brain loves sugar. I know we all know this. It loves glucose. And so that we start to notice someone really, really focusing on sweet things and over what we would call overeating sweet things as the dementia progresses. So that's something that can be used in your favor if you're trying to get someone to eat something. Turn up the sweetness. that might be a way to make it more palatable. Working on textures. So as I start to have trouble with the fine motor of chewing, we might need to chop things. So that would be bite-sized pieces. Fine chop, which is pretty much almost pre-chewed, and then possibly a puree as we go on. We're going to look at these things a little later. Slides here. I just want to show a video of an example of hand under hand. So you see this lady, Lucille, and Tipa Snow, who's the Positive Approach Care founder, has her hand in the hand under hand position with the spoon, and she's assisting her with eating. So this is someone who has not been able to feed herself for a while. I'm just going to play this video real quick.
It's good. Here you go.
I've never seen her open her mouth that big.
Yum. It's because her hand is coming to her mouth versus you poking her in the mouth with your spoon. And her brain going, whoa, what's that? Oh, wait a minute. Oh, okay.
Yeah, yeah.
Oh, it's okay. And this is like, oh, okay, I'm eating. Got it. That's pretty easy once I know what it is. Here you go.
Wow.
Isn't that fun?
Oh my.
Both of you are going to have a better time. And what I'm doing is supporting under her elbow. And so that gives her a little added information.
Okay.
And when I do that, she can sit upright a little bit better too. And I can judge.
Is this not amazing? I get thrilled when I learn something new.
Isn't that fun? Yeah. We're going to try the same thing with Miss Frances a minute and see if she's okay with it. See if she likes it. She eats fine right now, but time will come. Is it good, Lucille? Do you like chili? It's pretty tasty.
Wow.
Okay, I'm going to pause this video here. And I wonder if any of you noticed what Lucille does when she's eating with her eyes. She had her eyes open as soon as the food went in, closing her eyes to taste it. Have you ever found yourself doing that when you're eating something very delicious, for example? You really want to taste it. You put it in your mouth, everybody kind of do it. Close your eyes like, You close down one sense. I'm not going to look at anything and process any visual data. I'm going to focus all my attention on this delicious thing that's in my mouth, getting all the smells, all the feel, all the taste, all that. So Lucille is in the ruby going to pearl stages, late ruby, I would say. And she, multitasking is a fine skill. So focusing on one thing at a time. So you may notice people, this is another detective skill, closing their eyes when they're eating and chewing. Very, very common in the later stages. Completely normal.
It's good.
Oops, let me go forward here. So now we're getting to pearl, which is the last gem in the circle. This is where you'll see very limited interest in intake and drinking, real pronounced problems with swallowing, repeated infections, sleeping a lot of the time. So when Dr. Wen said I need to be alert, that includes being awake at all, because more time is spent with eyes shut and not alert sometimes than with alert. And because of a lot of times there are contractures at the end, and by contractures I mean go ahead and do this. Your muscles come on, but they can't go off. I'm constantly contracted, and even if you open my hands, well, one, it might be painful for me, but they won't stay that way. They will close back again. So at this point, I cannot feed myself at all, and it is very tempting to feed. So take a step back and take a deep breath and try and see what feedback they are able to give. So if a small amount of something pureed is able to go in and you can see the swallow and without other signs of choking, that might be okay. But taking your cue from them, because they are going to be giving you the signals of what they like, don't like, and can tolerate. And it's very, very, it's an extra challenging because, like Dr. Wen said, we eating together, feeding. Oh, let me make food for you. Oh, don't leave my house without food. We're good. And it's love. And we know that if someone is not eating, that they will die. That we all know that. But that body shutting down, that natural decrease in appetite, that natural, it is not a process, necessarily a process of suffering. It's the reason they are not eating is because they are in the final stages of life. They are in the stages of dying. Being able to accept that and let go of the need to feed, because it will not, as Dr. Wen said, to even the feeding tube, keep them on this earth longer with us. But what kind of time are we going to have together when we're here? Because there are things you can do around food that don't involve necessarily swallowing it. So if I am completely unable to swallow anymore safely, and that kind of aspiration where they've lost so much skill that they don't even cough it up. It's good when they cough and can tell you it's not going down. That's wonderful. But when you're at the stage where it's just dribbling down the small amounts of liquid, you're having me try to, it looks like I'm taking it, but I'm really aspirating it, and you will know because I will get pneumonia. Um, uh, they're being able to smell things. For me, Dr. Wood mentioned chocolate. That'll be it for me. Can I have a little bit of piece of chocolate on my tongue when my time comes? I could still smell and taste that. I don't have to eat the whole bar. It's 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 not necessarily about getting it in. It's how we can be together, smelling things. I've known families who just some family member just a tiny bit of whiskey, just the taste of it. My mother-in-law, who had a severe stroke at the end, just all she wanted was to taste a little bit of a whiskey sour. That was it. She had a stroke, and that was a wonderful thing. It was really quite joyful, actually. She couldn't swallow it. So what do you see? These are the things that you'll see towards the end. All these coughing, not necessarily even choking anymore, not coughing anymore. Um, my mouth stays closed more. Remember those contractures? So even if you're trying to get that spoon in, it's not going to go in. But there are things that you can help with. You saw in the previous video the hand under hand, but having pressure on the shoulder or forearm while helping someone take a sip if possible. Might need to have, definitely would probably need to have those thickened. Um, I'm going to go forward a little bit. So before I get into the details of preparing the food, it's all about with dementia, it's all about our relationship. And that goes with food or drink too. It's not just about our job of getting it in and getting it done. It's being together at this moment of time, wherever I am at this end stage of my journey in life, and how can we come together without fighting and walking together on this journey. So there are some physical things aside from the hand in hand technique that I showed the video of that can be helpful, because even though I say skill is being lost, it's not all gone, and there are adaptations that you can make to help me as my skill is changing. So adaptive plates that have rims around the edge. This little bowl has a rim around the edge, so that as I'm scooping, if it were a flat plate, I would go right off the edge because I'm not very skilled, but I come up at the edge. That might be something. Utensils that are more weighted. I'll have some resources at the end, fatter grips. Changing the consistency of the food. I'm going to go forward because I have a slide about that. So when you think about when I had you imagine eating, so if you had a whole piece of something, let's say, I don't know, you were eating a hot dog. I know that's a major choking hazard from hot dogs. But if you think about it, you pick it up in your hands, you take a bite, right? And you have kind of a big piece in your mouth. And then you chew it, and then it's smaller pieces. And then you keep chewing it, and then it's very finely chewed until finally you've chewed it so much and your saliva has come into play that it's kind of almost a puree. We probably don't chew it quite to the puree level, but then you're able to swallow it. So that's we go through all these modified consistencies ourselves when we're eating, but it just happens that we're able to do it inside our own mouths. So people who are living with the changing brain, later stages of dementia, that part is not working so much in their mouths anymore. And so this is where modified consistencies of chopping. So this picture here, This is chopped shoyu chicken. Rice, happy rice is already kind of fine chopped, so you don't have to worry about that. Gravy to make it moister, because people have dry mouth or saliva functions not working properly. This is soft kabocha pumpkin and some kind of chopped up broccoli, all the way to puree. So I know puree food gets a very bad rap. Like, oh my God, I never want to eat a pureed diet or pureed food. And I understand why it does, because it can be tasteless, honestly. But it doesn't have to be. And I know we've all had things that are pureed that are delicious. Um, Things like pureed soup, cream of tomato soup, any kind of cream soup. That is a pureed food. Um, you know, uh, Mashed potatoes, whipped potatoes, all kinds of desserts have that consistency. So you basically just push it around with your tongue and you can swallow it. You don't have to chew it. But the thing that those things I just described have in common is they're delicious. Pureed food can be delicious if we take the time to make it so. And then the liquids, that swallowing mechanism Dr. Wen was talking about, thin liquids. This is a thick food thickener. It doesn't add flavor, it just adds thickness. Is water. Nectar is like guava juice. Honey is like honey, of course. And pudding is, if you have pudding on your spoon and you tip it, it doesn't fall off. That's the thickness you're looking for. So that would be a recommendation that your doctor or speech therapist might make. Like, okay, this person needs honey thick liquids. Now, before I go a little further, in spite of all your efforts to make this the perfect thick liquid thickness, or the perfect chopped, or the even delicious pureed, sometimes people won't eat it. And I know that will be the case, and we'll talk about that a little bit too, because then we need to decide what are the choices that we have. So ways to add in flavor. So if you are needing to puree foods, the most common thing people think about adding in is water, right? So if I have um, uh, uh, something that is not liquid, like let's say broccoli, I need to puree broccoli. If you put it in the blender, you have to add some kind of liquid to it to be able to make it pureed so you can have it be that thickness. Think about adding flavor to that liquid, because when you add water, you're diluting, and that doesn't add flavor. So if it was a delicious broccoli on its own, it's not delicious when you just add water. It's flat. And so based on, you can use chicken broth. I love these bases. These are bases, base. So it's like a thick paste in a jar. Once you open it, you have to keep it in the fridge. But you can just get a little or a lot and scoop it out, and it dissolves instantly in a hot liquid. They're very, very easy to use to be a flavor boost. The other thing, and they teach you in culinary school, is fat equals flavor. I know a lot of times when we use the word fat in the foods, it's all about being bad, but no, fat is not all bad. Your brain does need some amount of fat in the diet, and it really adds flavor. And if you're looking to boost calories, you want calorie density, um, adding fat adds calories. So a little bit of butter, a little bit of cheese, things like that. And back to the sweet, honey, jellies, jams. It doesn't just have to be white granulated sugar, depending on the food, to up that to make it more palatable. And even with puree food, taste it before serving it. When you taste that pureed broccoli, does it taste good? Does it need a little more salt? If you were going to eat it, what would it need? There are things that you can get. I'm so happy to see Long's CVS carries now in their healthcare section. They have um, adaptive uh, utensils. They have adaptive plates. You can buy them online as well. These clothing protectors, there are adult bibs, not babies, clothing protectors, these scarves, you can sew them too. So they're kind of wide scarves. So it's very dignified. And then if you look at this picture of the spoon here, it doesn't just have a heavy weighted base, but the handle can bend like this. So if I'm using my spoon, as I have to turn it, come in, that's a skill. But let's say I can't do that anymore. It's hard, but if the spoon were bent this way for me, I could do it. So again, another little adaptation that we can make. There are a couple of cookbooks that are out there. This one is free, written by and for people living with dementia, which is so wonderful, about ways to help food preparation. And then this is someone I know from a women's culinary organization called Les Dames Escoffier. She wrote a book. She's a nutritionist, I think, about making smooth and tasty, easy to swallow foods. So those resources are there. So I'm going to stop share now and ask Jody.
Hello there. Thank you. That was a wonderful, wonderful presentation to both of you. What a dream team you both are. Thank you so much. Yes, I'll be on camera for a moment just to feed you these questions. I know you probably can already see them, but we'll take them from the beginning. What type of people or professional works with exercises for the throat and vocal cords?
Speech and language pathologists. So ask your physician to get your referral for speech and language pathology. They can do a really good assessment and they'll give you really good tips, and they'll probably work with you with exercises as well.
Thank you.
Exercise and strategies. They're really helpful.
And are they at every hospital? Is it easy to get an appointment? Do you need a referral to a speech language pathologist?
Probably need a referral.
Thank you. Okay. My mom has a habit of eating fast. She was trained to eat quickly during childhood in case of disaster events. Even I tell her to eat slowly or smaller bites. She doesn't. She doesn't follow directions very well. Any suggestions?
Yeah, it's well, one is it's not uncommon. People who grow up with a lot of siblings have that habit too. It's like, quick, get the last of it before my brother eats it all. That kind of a thing that's ingrained in you young. Yeah, and then the following directions. That's one thing. A lot of the kind of therapies or interventions that are common are a special challenge for people living with dementia, because that following directions and then remembering the directions you just told me is not in my skill set anymore. So one things, a couple tips I would say is, one is you know, because the thing that happens often, let me grab my spoon, is about eating fast is you don't have time to swallow. So you're getting like a ton of food in your mouth. So if someone ate fast and swallowed properly, maybe not a problem, but it's just maybe a smaller spoon. So even though they're fast, the spoon bowl might be a little smaller, so you're not getting quite as much in at once. We had a resident that we switched to chopsticks. She was still able to do it. And so that slowed her down a little bit until the very end of the bowl. Everybody knows what you do at the end with a bowl with chopsticks, right? You double it all, put it all in. But smaller portions, smaller spoon. Yeah, that's a couple tips. And Dr. Wen,
Yeah.
any
Yeah, no, sometimes, yeah, smaller portions, and then maybe, you have to, don't put all of it out at once.
right? Yeah, if you have the whole plate plus dessert plus yeah.
Yeah, and sometimes you might have to resort, to helping to assist feeding and cueing.
Yeah.
The cueing might be important.
And one other thing is cueing to take a sip between, like, oh, looks like you're really enjoying the food. Hey, let's have some water. Cheers. That kind of doing things together helps the relationship as well. And we all could stand to drink a little more water too.
Thank you.
Pause and ask them a question, and
Yeah.
What is the eligibility criteria for a hospice referral related to dysphagia?
I don't know if there's actually, it's usually related to some other diagnosis, dementia or stroke or Parkinson's
or they start losing weight, which can be
much
related
weight.
to the dysphagia. So like the consequence of dysphagia, generally, because people can have dysphagia and still be eating with a modified diet and not losing weight, modified consistency diet. So just because you have dysphagia doesn't necessarily mean the life expectancy of 6 months or less. But certainly as it progresses, it would.
Yeah, definitely weight loss criteria, I think.
Yeah.
And then they might do the arm circumference as well.
Ah,
Okay. What type of people, oh, we already got that, sorry. My husband has Alzheimer's and was put on nectar thick and pureed food as the result of what was thought to be aspiration, but it was later suspected it might be a cold caught from a sick child. Can we safely check again for a less restricted diet?
Absolutely. People change.
absolutely. Mhm.
And
Yeah.
as I said before, sometimes when people get sick, they get very tired, or if they take a medicine that makes them very, very tired, it doesn't mean that they're doomed to this, trouble swallowing, aspiration, risk forever.
Mhm.
Take away the sick, if the sickness gets better, or if their medication that impacts their alertness or their dry mouth improves, then yes, definitely
Yeah.
try go back.
Yeah, usually
I
there's
always
usually
try
they
to.
set a trial, like a little trial, but let's try it and see how they do. And I think I mentioned it, but forgot to follow through with it. Is um, sometimes it doesn't, if someone can not want to have the puree, even though you've done a great job and made it delicious, and so then you know even though there's a risk going back to a non-puree diet for this individual, it's what they want and will tolerate. If they're not going to eat the pureed food, there's no point in it. Yeah.
Okay, we rely heavily on silicone straws, but have seen conflicting advice regarding their use. Are there any concerns here?
About the silicone or a straw itself? Because I know there are conflicting advice about whether to use straws, period, for people who are with dysphagia. But I haven't really thought about silicone versus paper versus metal versus any of that. But if you think about sucking through a straw, um, that's air and food. And we know we're already having trouble managing the different, getting where the air is supposed to go versus where the food's supposed to go. So a lot of times I know straws might not be recommended for the later stage. Is that correct?
Yeah, I tend not to recommend straws. I'll defer to the speech therapist, but I tend not to recommend straws at all. The problem with aspiration is that things are going down too quickly for the reflexes to stop them. And that's why we go from thin to nectar thick to,
Slow it down.
slow it down, so that if things go through more slowly, your reflexes can catch them before it goes through. So a straw is too quick, I think, but
But in
better.
earlier stages of dementia, a straw might work fine.
Yeah.
So.
And it's very individual.
Hmm.
Suggestions on how to deal with loved ones who cannot comply with dental care, but likely have pain and eating trouble due to teeth damage.
Yeah, that's again very, 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 very common.
Dorothy just did a whole thing
Yeah,
on
we
dental
did a
care.
whole thing on dental care. The thing about dental care is I actually also have a prop toothbrush. Of all the kinds of care we give, to personal care, peri care, genital area care, oral care, it really involves sticking something inside somebody. It's a very invasive process. And remember, I was saying this is highly sensitive anyway, and now it's hypersensitive. So I I just cannot tolerate that. So that's a whole nother webinar. But um, uh, even simple, just rinsing and spitting with water is something that can be really helpful. But someone has pain, I know it can be hard to get someone to the dentist, and a lot of times people can't do it until it's so much that they don't really have nobody has any choice about it. But if there are ways to modify the food, softer food, wetter food, so that someone has sensitive teeth or things like that, that they could still eat even with very few teeth or sensitive teeth. Anything else, Dr. Wen, that might be?
Yeah, I want to comment on Ben's comment about the pocketing food, because he also talks about the oral swabs and the soft toothbrush and using the finger caught
Mm-hmm.
thing
Mm-hmm.
inside to, I guess you could use that actually
Mm-hmm.
to break up or get out
Yeah.
the not the caries, the plaque.
Yeah.
and rub that off. And the other thing that I would say for people with trouble brushing, like as you mentioned before, very, very small motions instead of big ones.
Yeah. Yeah.
And
So we think about brushing as this, but just think of it more like vibrating, as opposed to scrubbing. You're not
yeah.
scrubbing your bathtub. Yes.
Mhm.
But yeah, softer. The regular adult soft toothbrushes are honestly not that soft. So even going to like child soft, which also has a nice smaller head, might be something that's helpful. Try it on your own skin and feel what it kind of feels like, and that'd be a good
Mhm.
little practice. And thinking about which I learned this from the dentist I did the webinar with, which part of your teeth really are, if you accept that you can't do the perfect 2 minutes of brushing like your dentist recommends, where do you want to focus your efforts on? And the flat surfaces of your molars are not where the food accumulates. It's down next to the gum line. So if you can get just a little bit on the gum lines, and if you only get one quadrant this time, take a deep breath and pat yourself on the back and say, yay. And next time, maybe you can get the other quadrant. So accepting our limitations together, because
Yeah.
we don't want to get into a fight and force.
And if you can't get rid of the plaque, you can kill the bacteria anyway. So, mouthwash is a good thing. I use plenty mouthwash for that. Just to swab in the mouthwash. But that helps. Anyway, but that's not
Thank
to,
you.
but
Does drooling indicate swallowing problems?
well, I would say that drooling indicates that you're having difficulty managing fluids in your mouth. And if you're having difficulty managing fluids, most likely you're going to be, if it's not now, it will be in the near future. That will probably be an issue to really be on the lookout for.
Yeah. So, because the drool is your saliva. So the issue is, are there issues around saliva production or overproduction? But also, you need your lips to keep the saliva in. And let's say you've had a stroke or so, and then that seal of your lips is just not as good as it used to be. It's just going to come out. So, it's very individual. So looking at, yeah, but yeah, it's one of the clues.
It could be difficulty in the oral part, but it could be difficulty handling fluids in the back as well. So it'll kind of depend. But I think talking to your physician will help clarify that. And, say if you have Parkinson's or something like that, then maybe even trying to, manage the medical condition a little bit better may help, with maybe with the dry mouth or the medications to increase fluid or, other strategies. So
Thank you. I'm going to read this out loud for people on the phone. My wife is in late stage dementia and is starting to have swallowing difficulties, including pocketing food in the cheeks. To remove food, I use disposable oral swabs, a very soft toothbrush, and a 360-degree finger toothbrush for pets. Looks similar to a finger with bumps. This last is by far the most effective, but risks bitten fingers if inattentive.
Yeah, I believe it. Yeah, those are great. Those are great tips. Yeah.
Thank you. Okay, impulsive eating caused speech therapists to recommend moist chopped food. Adult day health care does not chop food served. I've seen what usually looks like ground beef in gravy. Wouldn't chopped food be closer to a more nutritious meal and allow elderly to use teeth to chew and maintain oral strength?
So, I would consider ground beef to be pre-fine chopped. In terms of like when I was cooking and preparing food for the elderly. If you start with a piece of meat that's whole, then chopped would be, small chunks, and then fine chopped would be close to grain of rice size. That's generally what they say. So the nice thing about ground beef is that it's it's already kind of pre-broken up like that, and the gravy is the moistness. Um, so in terms of complying with a chopped diet, that ground beef and gravy would be considered a chopped diet. And so the nutritiousness of the meal comes from the ingredients, not from the consistency. So but using the teeth and the thing about setting like a adult day program or any kind of communal setting is you have all kinds of people with all kinds of teeth and all kinds of swallowing issues. And so a dish like ground beef and gravy is one that probably hits a lot of the dietary and eating requirements for a lot of the people there, is what I would imagine. Sorry.
And the other thing I want, yes, exercise is important, but what I've noticed sometimes is that some people are very tired and they're fatigued, and chewing is a lot of effort. And if they spend all their energy chewing, they eat less. And if you want
Mhm.
them to get more calories in, more
Yeah.
nutrition in,
Mhm.
sometimes making
Mhm.
it easier to get the food in
Yeah.
is takes precedent. And then maybe, later on you can do the exercises. But if you want the
Yeah. Yeah.
nutrition to go in
Yeah.
before they
And the
fatigue.
and the modification of being chopped at all is acknowledging that the biting and chewing is compromised in some way. So there, we have to do some of that for them by changing the consistency. But also the meal at the adult day is just one out of many. So, if someone is not actively, exercising these muscles that much, it's okay. It'll be
Yeah.
okay. Yeah.
In fact, some people eat better in the morning. The breakfast is their
Yeah.
best meal, and they get
Mhm.
really tired by the end of the day. And so
Mhm.
something simple and soups and stuff like
Mhm.
that by the
Mhm.
end of the day when they're
So
really tired.
if
So
if the person is enjoying it, I'd look to, are they enjoying the food? Are they doing okay weight wise? Then if those two things are yeses, you know, everybody clap, because that's no small thing. You enjoy your food and you're not losing weight. Great. Yeah.
Thank you. My dad's hand just started shaking. He's had dementia for 6 years now. Is there anything to reduce the shake?
I guess it just depends on what the problem is. If it's an
Mm.
intentional trauma, there are medications for that. You don't want to medicate everything, but um, if it's Parkinson's, that's a whole other issue. On the other hand, there are weighted spoons and forks that
Yes.
can help reduce that. And then, of
Yeah.
course, you can do the hand under hand approach, and
Yeah.
then do the assisted feeding.
So like if I had a tremor and I was holding a paper cup, that would be very shaky. But if I'm holding a weighted cup, this mug is kind of heavier. I still have my tremor, but it shakes less. So that's what those weighted spoons do. So we've had residents who, with a regular spoon, like everything's going to come off that spoon, but with the weighted spoon, it dampens it, is what it does, and then they're able to use that weighted spoon
Yeah.
effectively.
And then, of course, adapt your food so you don't have to, don't, maybe not peas, but,
Yeah,
maybe
something that
something else
things that
that sticks
stick to
to
the
the
spoon.
fork.
Yeah. Also, they make those adaptive spoons have like when I was talking about plates with lips, the adaptive spoons, this plastic spoon just is smooth. They make them with little lips around the edge. So it does help hold it in a little, because it's designed for people with Parkinson's, things like that.
Thank you. My mom is in mid-stage dementia. Her tastes have become very limited for what we cook. She seems to eat a lot more if we go to a restaurant, but at home she tends to binge on sweets, as you're saying. She'll eat a whole apple pie if it's in sight. She forgets she has had a piece already.
Mm-hmm.
At what point do we worry about their health versus just what they will eat? Steak and lobster versus veggies and healthful but decently tasting foods. She has high blood pressure and cholesterol.
Yeah, yeah. I think the key is yeah, I'm smiling because it's so common, and it's not just common for people living with dementia. You walk into the break room at your work, and there's like a whole thing of malasadas in there. If you see it, if it's in sight, is really, as human beings, when we see something, and then that primitive part of the brain says, "Oh my God, I love apple pie," or I love potato. It's really hard to pull those reins in and not eat it. But we have impulse control, and we can remember that I already had a malasada, so I'm not going to have another one. But those two things are lost for someone living with dementia. So I don't remember I had that piece of pie, and I have zero impulse control. So I will eat the whole pie and then not remember that I did it. So I think for me, the thing that stands out is if it's in sight. So if sure, great, enjoy a piece of apple pie, but that the rest of that apple pie has to be someplace else that is not in sight, out of sight, out of mind. I don't know if you have an outside fridge or someplace, just someplace else that can live, because it's not purposeful, and it's hard to say no. It's like, but you just had one. No, I didn't, and then you're in an argument.
Yeah, and then the other principle I just want to throw in is moments of joy, right? And people in mid-stage dementia, they don't really get the future and why it's bad for them in the future and what the past is, who cares?
Mhm,
It's the moment.
mhm,
And
mhm.
what matters to them is that they're happy now. And so
And
if
then the
that's
one
what
thing
you
about,
yeah.
yeah, and the in the moment goes back to the part about the restaurant. Um, that's a very social environment. With a set of kind of when you eat something in the restaurant, when you're done, guess what? They take it away. It's that they give you one piece of pie, and then they take the plate away, and you're not tempted to eat more. So it's in some way it's a much more controlled experience than at home, where there's almost infinite amount of things. Sometimes the rest of the pie, the rest of whatever it is, that little lobster, something like that.
May I just
So
add that, if she's worried about nutrition getting in and the person's
mhm,
eating too many sweets, I knew of a lady that only wanted chocolate milkshakes. That's all she
mhm,
wanted in late mid-stage dementia, sort of.
mhm,
And the doctor recommended sneaking carnation instant breakfast in there, or ensure might not taste good, but you can mix the carnation instant breakfast so they could get the
mhm,
vitamins.
mhm. Yeah,
Um,
yeah,
anyway,
yeah,
the same person
yeah.
here, another example is I do let her drink half a jug of juice versus limiting the sugar. If she doesn't want just water, I try
Mhm,
to water down the juice once there's room in the bottle, but she seems
mhm,
to go
mhm,
through juice like crazy, and I end
mhm,
up not
mhm.
wanting to buy juice.
That's sweetening. Yeah, just a little bit of sweetening. Yep, yep. Yeah. Watering it down if she doesn't notice or object to it, then great. Yeah, there really is that balance of I'm a big advocate for, in general, liberalizing diets as much as humanly possible. That person who asked that question, just from the question, it doesn't sound like her mom is at the very end stages where they're unable to, if they can eat at a restaurant and eat apple pie and things, that that's would be harder for someone in the ruby and pearl later stages. So there's a lot more flexibility there. But yeah, we had a resident once who only wanted ice cream, nothing else. And we used to put the Ensure chocolate ice cream in particular. We used to put the Ensure into an ice cream maker and make it into ice cream and then scoop it out like it was ice cream. And you could have all the ice cream, quote unquote, ice cream you wanted, but it was really Ensure.
Thank you. What is meant by a wet voice?
Okay, so it's connected to the next question too, I think. But a
Mhm.
wet voice is when liquid gets pooled in the back of your throat. When you're swallowing, how the bolus kind of goes to the back of your throat and it goes right by your vocal cords, and then there's some fluid that pools there. If that's not cleared, sorry, if that's not cleared, then you could feel like you gotta, a little bit
I,
gurgly,
I,
you gotta
I,
clear it.
I, you kind of like a bubbly sound. When I'm doing it, I feel it coming up my nose too. When I just did that little demonstration, it's like, oh, I just can't get it quite out.
So food is stuck in the back of the throat and gets and you're trying to clear it and it's kind of sticky phlegm-ish. It's because it's not getting it's escaping a little bit. So
Yeah. So
I
you
would
hear
say
a
maybe
wet sound when they're
it's not
talking. So
being
maybe
properly swallowed.
not quite coughing. It's not a coughing. It's like,
Yeah.
yeah.
I would probably do, you know, double swallow or more
Oh
swallows
yeah,
or
yeah.
something like
Oh
that.
yeah. So the double swallow. I was thinking about this after one. So let's say I eat something, take a bite, and you can see I haven't swallowed it. It's like maybe in here. Let's say you're helping me. If you give me a second bite with nothing on my spoon, that might trigger me to swallow the first bite that was on the spoon. Or instead of giving me another spoon, a little sip, even if you don't get the water into my mouth, just the act of like, then I might swallow. So it's like a fake out second second swallow without adding more food into it.
I'm just going to read this for people on the phone. My mom sometimes says the food or drink is stuck in her throat, and then for about 10 minutes, she spits up clear, a very sticky phlegm. Thoughts on how to treat this?
Oh, well, that's what we just talked about. But also, my other thought is it could be postnasal drip too. I mean, some people have a lot of congestion and stuff, and it might be something you might want to talk to your doctor about if you need
Yeah,
congestions or something.
yeah, get an evaluation done. People with chronic bronchitis like COPD cough up a lot of phlegm too. Uh, yeah, yeah, yeah. Just getting it checked out to see what the reason behind it is. It may end up being that she might need a change in consistency because it needs to be easier for her system to swallow down, a thickening of liquids or wetter food, something like that.
So we're right at 11:32. I just hope you guys can give closing statements. Dorothy, as a professional chef, could
Yeah,
you talk
yes,
about maintaining the joy in eating? And Dr. Wen, as a doctor, compassionate doctor, could you talk about those moments of joy and how important they are with food?
yeah. Uh, I think I'm kind of stealing Dr. Wen's moment. I think of eating at all the stages as the most wonderful opportunity for moments of joy we have together in this relationship with the person we're supporting living with dementia, and for ourselves too. If we can take the pressure off ourselves of thinking about getting it in to just being together in the moment, and whatever, I've made this delicious pureed food for you, whatever amount they're able to enjoy, and that's good. That is good. Just uh, um, uh, it's uh, it's a journey together, and food can really be a moment of joy. And the social eating. The other tip I would give is uh, is sitting down as opposed to just here's your food, coming back later to check if we eat it. Take a moment and sit down together, and maybe serve yourself a little something too, because nobody likes to eat by themselves, uh, and that's all. It can often can be the case.
Yeah, I think that, at this stage in life, you oftentimes, if you're having trouble with dysphagia, you are kind of at the last chapter of your life anyway. And what matters at that point anyway? I mean, is it, low cholesterol and low sugar and low salt diet? It's just really like, you know what? Just can I just enjoy? Can I just enjoy my food, enjoy my relationship with you? I don't want to be bad. Let's not make it a battle. Let's just enjoy
Yeah.
each other and just be mindful and enjoy the taste, maximize what we can.
Mhm.
I would often ask, what's their favorite thing? You don't have to, oh yeah, no, I cooked this whole, they wanted a steak and I cooked the whole steak and they didn't, then they took one bite and that was it. No, that's exactly right. They wanted to have the really great one taste,
Mhm. Mhm.
whatever,
Yeah,
that's
yeah,
the joy
yeah,
that you're trying to
yeah,
capture.
yeah.
If you can't get
So,
anything else, you need to capture those moments of joy.
yeah, simple, familiar things. We all go back to the comfort foods. If you think
You
about,
know what?
yeah,
Spam,
yep,
fine. You
yeah,
know,
absolutely. Hands down. We cook all this great food at Holly Cake, but when we serve Simon for lunch, heads down, like nobody's talking in that dining room. Everybody is like, Simon is like the number one favorite food. Think about it. It's very soups are comforting, childhood food, and then the number one favorite dessert, ice cream. Ice cream by far. Yeah.
Well, you guys are amazing. Thank you so much to both of you. And thanks to all of you that attended. And I guess that's it for the day. We'll be in touch with more webinars coming up. We appreciate your suggestions. Thanks to everybody. Have a wonderful rest of the
Thank
week.
you.
Thank you.
Thank you. Bye, everybody.
Bye-bye.
bye.